of expression. Hey. Hi. So, okay, we'll get started. My name's David Spanner. I work at Sunnybrook. We have a CLL clinic that sees only specialized clinic that sees only CLL, which is probably why I was asked to do this. So I'm going to talk to you about the biology and management of chronic lymphocytic leukemia. I know you've had some introductions to this in previous sessions, but there are some unique aspects of the biology of CLL that I think it's important to mention. So the outline of the talk is that we'll first demonstrate that CLL does develop like any other cancer, talk a little bit about some of the mutations that underlie CLL that have been developed in the last few years, talk about factors that promote the growth of CLL cells, some strategies for the watch and wait period of management. Then the last half of the talk, we'll talk about the drugs that are currently used to treat CLL and why they can't cure on their own, and then mention the current and future treatment approaches. So what is cancer? Cancer is a class of diseases characterized by uncontrolled division of cells and the ability of these cells to spread throughout the body. All cancers go through three phases: initiation, promotion, and progression. Initiation is when the cell of origin of the cancer gets transformed by genetic damage. Promotion is the provision of factors that tell the transformed cell to grow, and in the process of growing, it acquires additional mutations and undergoes progression and becomes more malignant and results in symptoms that need treatment. So all cancers bear certain hallmarks. They include, they're composed of cells that have a limitless potential for replication, that can grow where they shouldn't, that are insensitive to normal signals in the body that tell cells to stop growing. They can sustain their own growth. They can evade apoptosis, or they can, meaning that they don't die, they can outwit the normal processes in the cell that tells damaged cells to die. And importantly, they can also learn to evade the immune system. So immunosuppression and resistance to T cells, which are cells of the immune system which help kill damaged cells, is also a hallmark of cancer. How do cancers get into that situation? They develop mutations in important signaling properties that control the growth of the cell. So many of these mutations are involved in called oncogenic mutations, are in cell pathways that tell cells to grow, and the mutation is such that that pathway is always on, always telling the cell to grow. There can be inactivating mutations in genes and proteins that are involved in telling the cell to stop growing. So these growth inhibitory signals are corrupted. Importantly, because cancer cells sustain a lot of genetic damage, there's a very strong native property of the body with a DNA damage system that basically kills cells when they get too genetically damaged. And so a hallmark of any cancer cell is the inactivity of this DNA damage pathway. So there's certain genes that produce proteins like something called P53 or something called ATM, which mediate this DNA damage pathway, and those have to be knocked out for cells to die. For cells to not die, rather. So with that as a background, what's the cell of origin of CLL? How does CLL arise? So in CLL, the cells that are transformed are B cells. B cells are cells of the immune system which develop in the bone marrow and go out into the blood and then traffic through lymphoid organs called lymph nodes and spleen. And what they are characterized by is each one of them has an individual molecule called the B cell receptor. And this receptor is uniquely able to recognize antigens, which are foreign structures, mainly found on infectious agents like viruses and bacteria. And the B cell receptor can recognize those structures, and then signals from the B cell receptor are sent into B cells, telling them to proliferate, to build up their numbers to large enough levels that they can secrete their B cell receptor. It can bind to the foreign agent and help clear it. So somewhere along this pathway, B cells pick up genetic mutations that stop them from functioning in the normal homeostatic patterns of normal healthy functioning, and are the cell of origin of CLL. So what happens when that transformed B cell, over time? Promoter factors allow it to proliferate to large enough numbers that you start to see it in the blood. And how you see it in the blood is that you go to your family doctor, he does your yearly physical or your yearly checkup, he does what's called the complete blood cell count, and the lymphocyte count is a little bit high. So then to identify what those lymphocytes are, a test called flow cytometry is done. And in particular, what flow cytometry does is it examines two markers that are found on CLL cells. One is a marker called CD5 and one is a marker called CD19. If you look at normal blood, cells with this type of pattern are very low in the blood, but with CLL, they start to grow, and you can see them, and that makes the diagnosis of CLL. So what are the initiating events in CLL? What's the genetic damage that underlines the development of these cells? Well, in the last 4 or 5 years, with the advent of the ability to sequence genomes, with new technologies that allow us to easily sequence the entire chromosomes in a cell, a number of genes that are mutated in CLL have been identified. And there's about 40 of them. I'm certainly not going to go into them, but they fall into the same categories of oncogenes that underlie the development of any cancer. So B cell receptor signaling is very important in stimulating the growth of CLL cells. The mutations that arise in CLL are those in pathways from the B cell receptor, making these signals always on so that the CLL cell will proliferate. Additional growth promoting factors have been identified with this type of analysis. So signals from a pathway called the Notch signaling pathway are also important and always on in driving the growth of CLL cells. And then the usual culprits in cancer development, the inactivation of genes involved in controlling DNA damage, getting rid of cells that are too damaged. These genes are mutated in many cancers and in CLL as well, and things like P53 I've mentioned and ATM I've also mentioned. So there's nothing really different about the genetic changes that occur in CLL from other cancers. There's some variations, but overall the themes are the same. There's another important marker that helps divide CLL into two different types, and that's the mutations in the B cell receptor itself. So when the B cell receptor, when B cells come out of the bone marrow, their B cell receptor is composed of genes that are found everywhere in the body, in every cell in the body. And so the B cell receptor is then referred to as being unmutated. In the lymph nodes, once a B cell encounters an antigen and starts getting stimulated through the B cell receptor, there's a protein in these regions that actually deliberately puts mutations into the B cell receptor. And the reason for this is to increase the activity, the ability of these B cells to be able to bind to the foreign objects, the antigens that have stimulated them in the first place, and more efficiently clear the bacteria or the infectious agent. And so this type of mutation, which your doctor will probably talk to you about, is a little bit different than the oncogenic mutations that I referred to in the previous slide. This is a more physiological type of mutation rather than a pathological or disease-causing mutation as in the other genes. But what the result is that CLL cells even though they look the same in terms of expressing CD5 and CD19, can be very different in terms, are also classed as being mutated, and they talk about mutated meaning IGHV mutation or the unmutated type of CLL. And so although the diagnosis of CLL involves the overgrowth of cells that express CD5 and CD19, you can see that the underlying genetic mutations in these cells can be very different. The B cell receptor can be very different. And what that means is that the clinical course of CLL, once you get diagnosed, can be quite variable. In some patients, it can be very benign, and in some cases, it can be quite progressive. Symptoms develop rapidly, and treatment is initiated early after diagnosis. This is a figure actually from 2007, so it doesn't really apply in today, but it does emphasize the variability in the disease. So this is a figure where patients who are, the percentage of patients who survive after the diagnosis of the disease, and this is the time in which that they're followed. So quite a long period of time, 192 months, many years. So if patients have lost a region of chromosome 17 that encodes that gene pre-53 involved in DNA damage control, their survival was actually only about 5 years after the time of diagnosis. If they lost a region of chromosome 11, which encodes that gene called ATM, again involved in DNA damage control, again the survival was not long. If patients had the mutated IGVH status, if their B cell receptor was mutated, and they didn't have these so-called high-risk lesions, then the disease course can be quite benign, with some patients really having no problems for 20, 30 years, so having quite a benign disease. And then the mutated B cell receptor falls in the middle. So these curves, again, based on survival, really don't apply anymore. This was long before we had some of the drugs that I'll talk about later that are much more effective. But it does illustrate the point that the disease course can be quite different for each patient. So there are some markers that you can look at that can give you some insight at the time of diagnosis about how rapidly the disease will progress and when you'll need some treatment. Talked about these chromosomal changes. Some of the newer mutations that have been identified in the last few years seem to be associated with more rapidly growing disease, so things like mutations in Notch1 and other genes. We've talked about the IGVH mutational status being important in telling how rapidly disease will progress. There's some molecules that are expressed by the CLL cell that can also help guide you. So if CLL cells have high expression of a molecule called CD49 or ZAP70 or CD38, in general, they grow a little bit faster and require treatment earlier. Markers not associated with the CLL but found in the blood are also useful. There's one called beta-2 microglobulin that's usually measured at clinic visits. And if that rises well over the normal range, that's usually associated with someone who will need treatment earlier. These markers, CD23 and thymidine kinase, are used more in Europe than in Canada to guide prognosis. However, the best way to actually decide to figure out how rapidly the CLL cells will grow is to just look at it and just follow the patient over time. And one can use the CLL cells in the blood, the number of CLL cells in the blood, to guide you as to how aggressive or how rapidly the disease will progress. And so what the doubling time is simply is you look at the white blood cell count on day 1, and then you look at it again on a year later and a year later after that. And if the lymphocytes, the CLL cells, double within about 6 months, it's not rocket science to figure out that you're going to accumulate a large number of cells fairly quickly and need some treatment. On the other hand, if the doubling time is several years, you can do the math and realize that there will be many, many years before you'll need some active treatment for the CLL. So this is the life cycle of a CLL cell. we measure them in the blood, but they have a very dynamic behavior. They circulate in the blood, but then they go in and out of these microenvironments in the lymph nodes, spleen, and bone marrow. And in these microenvironments, they get additional signals. This is where they grow. They don't grow in the blood, they grow in these microenvironments. And so in the microenvironment, signals are provided that help stimulate the B cell receptor. Other signals are provided that support the growth of the CLL cell. And then the CLL undergoes a few rounds of proliferation and comes out of these areas, circulates in the blood, goes back again, and goes back and forth and gets these bursts of proliferation. So what's been noticed is that if the CLL cell has sort of the more aggressive mutations or the mutated or the unmutated B cell receptor, their response to these types of signals is much stronger. They proliferate much more than, say, a CLL cell with a mutated B cell receptor and no 17p or 11q deletion. And so those types of cells have a very sort of inert behavior. An important promoter of CLL actually appears to be hypercholesterolemia, high levels of cholesterol in the blood. Turns out that many CLL patients have high evidence of high cholesterol in their blood. And one of the things that we've done in Sunnybrook is shown that CLL cells actually internalize that cholesterol and put it into the membrane of the CLL cells. And that then helps allow the CLL cell to respond more strongly to the signals in the microenvironment and grow a little bit faster. And an important point to realize is that it's not good for CLL cells to proliferate because in the process of proliferation, they undergo progression. And progression is the accumulation of additional mutations. So if at the time of diagnosis, you may have a very bland form of CLL. All of the CLL cells are of one type. But as they grow, they pick up additional mutations. And the population of CLL cells becomes more diverse. And in particular, with treatment that is not curative, what can happen is that it changes dramatically the makeup of the CLL population. So, for example, what can be done is that you'll select for mutations that can become resistant to those treatments. And then over time, then the CLL cell, the more aggressively mutated CLL cell will expand and change the population of cells compared to what you're starting with. They're all CD5, CD19 positive, but they bear different genetic mutations and can be more aggressive. And this is sort of an example. I've said that loss of P53, ATM, and then this mutation in Notch1, one of the newer mutations, are associated with more aggressive disease. And you can see that what's been done here is that these genetic mutations have been measured at the time of diagnosis, at the time that the disease has progressed to causing symptoms that need treatment, and then at the time that the CLL cells have become resistant to these treatments. And you can see that in each case, the more aggressive mutation gets selected for. So CLL, as I said, can have a very heterogeneous course. Some patients can have high numbers of CLL cells in the blood but feel well, and so they don't require any treatment. The disease really only becomes a problem when the leukemia cells grow to large enough numbers that they start to cause symptoms. And how they cause symptoms is that they start to grow in the bone marrow, start to compete out the normal cells in the bone marrow. So the bone marrow normally makes red cells that help carry oxygen. They make platelets that help prevent bleeding. They make other lymphocytes that are involved in protection, other white cells that are involved in protection against infectious agents. And so as the CLL cells grow, they impair these functions. As the hemoglobin falls, you can get anemic. When you're anemic, you feel weak, sometimes short of breath. As you impair your normal white cell functioning, you can get prone to more infections. As the lymphocytes, as the CLL cells grow to large enough numbers, they start to use up nutrients that should better be used for your healthy tissues, And so muscle weakness, weight loss, and fatigue can all start to become disabling, in which case then treatment is indicated. So this is the typical course of a CLL patient, and I've drawn it as with a timeline that we would have seen prior to 2014, when a number of new drugs became available. So upon time of diagnosis, conventional management is to simply watch until symptoms develop. So this is called the watch and wait period of time. So when you get diagnosed, treatment is not initially started. The doctor needs to get an idea of if you'll need treatment or how rapidly you'll need treatment. But once enough symptoms develop, then first-line treatment is given. Generally, that works very well, but it's not curative. It also changes the disease that's left behind. And so what happens then is an inevitable recurrence. This time, cell population is different. Before 2014, the drugs that we used were generally variants of the same drugs that were used in first-line treatment. So this time, the depth of response, the amount of cells that could be cleared is less, and the length of time before they grow back to cause more symptoms is also less, and that's repeated. And eventually, the CLL will become resistant to these types of treatments, and then there's not much more that can be done. So prior to 2014, a rough sort of time frame would have been from the time of diagnosis, from the time first-line treatment was initiated, that probably there was about 10 to 15 years before you ran out of options in terms of what could be done. So regarding the watch and wait phase, many people say, well, why not treat at diagnosis? You've got a diagnosis of CLL, why not treat? And one point is that CLL, although it's treatable, it's not curable. So, it's the disease, the philosophy of management is it's a chronic disease. That's why chronic's in the name. And the chronic illnesses are just managed over time. Studies of treatment at diagnosis versus treatment when the patient got symptomatic, these were from the 80s and 90s, showed no difference in survival of patients. And importantly, not all patients will require treatments. You're not going to treat everyone blindly, but all treatments have some side effects. So you only want to have the patient experience side effects if they'll derive a real benefit from the drugs. And the benefit is not just dropping the white count into the normal range. And then we've discussed this fact that any treatment that's not curative changes the disease that comes back and makes it more aggressive. So treating earlier with ineffective drugs that can't cure can potentially shorten the lifespan down the road. So a philosophy generally among CLL physicians is that the watch and wait period is generally a passive period of time, which simply just sees the patient and then waits until symptoms develop. At Sunnybrook, we have a bit of a different approach. We actually think that this watch and wait period of time is a great period where active interventions can be done to decrease promoter factors which can stimulate the CLL cells to grow. If you can delay their proliferation, you can delay the time when they'll cause symptoms, and you'll also delay the acquisition of more aggressive mutations. And so, in particular, one thing we pay a lot of attention to is hypercholesterolemia. I alluded to that a little bit earlier. In our clinic in Sunnybrook, of several hundred patients, we found that nearly 80% of them have evidence of high cholesterol levels in the blood, and we confirmed this with a study of 10,000 patients in Ontario using administrative records. We think that the association is actually, as I mentioned earlier, that the high cholesterol levels appear to be promoter factors that allow CLL cells to proliferate faster, and that then lowering cholesterol seems to slow disease progression by several years and may even increase overall survival. So this was from a study that was done at Sunnybrook looking at 10,000 Ontario residents and using administrative databases and correlating a diagnosis of CLL with the use of a cholesterol-lowering agent and with the use of a cholesterol-lowering agent and basically looking at survival. So it was records, again, from retrospective records from data from long before the current treatments were available. But what it showed was that if you were on a lipid-lowering agent, you could see that the time of survival was actually extended by about 3 or 4 years, which is really quite an impressive result. So at Sunnybrook, we really pay attention to the cholesterol and advise that lowering cholesterol levels should be really the goal of the watch and wait period of time. And how you can lower cholesterol levels, you can do it by significant weight loss, completely getting rid of an abdominal fat pad, exercising significantly, and this involves strenuous exercise, not just walking the dog. And in some cases, we'll actually institute cholesterol-lowering drugs like statins. Note that, again, none of this is from randomized control studies. This is basically our approach at Sunnybrook, but we think it's backed up by the science. So lowering cholesterol is a treatment for CLL, not generally thought of as being a treatment for CLL, but as every treatment for CLL is essentially, for the most part, not curative. So eventually, CLL cells will be selected for that are no longer controlled by that particular treatment strategy. So over time, then, the CLL cells will grow to large enough numbers that they start to cause symptoms, and you have to start talking about first-line therapy. So we have essentially 4 classes of drugs that we can use to treat CLL, and I've grouped them into the ones we had before 2014 and the ones we have available to us after 2014. So one class of drugs is cytotoxic agents, and these are drugs like fludarabine, chlorambucil, bendamustine, and glucocorticoids. Recently in Ontario, we're able to use a drug called venetoclax. Before 2014, we had no kinase inhibitors. After 2014, a drug called ibrutinib has become available, which has made a huge change in the management of chronic lymphocytic leukemia. There are some other kinase inhibitors like idelalisib that are used. There's one called acalabrutinib, which is not yet licensed in Canada, but is probably going to be licensed very shortly and will be used to treat CLL. We have antibodies. Before 2014, we had one called Rituxan. After 2014, we have an additional one called obinutuzumab. And in terms of T-cell immunotherapy, I'll talk about bone marrow transplantation, and after 2014, touch a little bit on what are called CAR T-cells. And so what I'm going to do is go through each one of these classes of drugs and try to sort of tell you how they work, and more importantly, tell you why they can't, how easy it is to develop resistance to them, why they cannot be curative on their own in most cases. So first with cytotoxic drugs. So what the drugs like fludarabine and cyclophosphamide do is they cause a lot of genetic damage to the CLL cells. And that damage is communicated into what a cell death pathway. So cytotoxic drugs cause CLL cells to undergo apoptosis, the process of programmed cell death. They tell the CLL cells to die. And so, as I said, what drugs like fludarabine and cyclophosphamide do, and even what glucocorticoids do, is they activate proteins called BH3 proteins. And what these do is then activate 2 proteins called BAX and BAC. And what BAX and BAC do when they're activated is they go into the membrane of a mitochondria, the powerhouse of a cell where energy is generated, and they poke holes in that membrane. And that causes proteins to be released into the cytoplasm of the nucleus, and those proteins basically just chew up every structure in the cell. They just chew up the cancer cell and spit it out. And so that's how these cytotoxic drugs are supposed to work. So it's very easy to see how the CLL cell can learn to evade those types of drugs. They can inactivate the signals which signal to these BH3 proteins. And these are controlled by proteins like P53 and ATM, and that's why they're so invariably mutated with the use of these types of drugs. In addition, there's another way that without mutating P53 and ATM that cells can survive the cytotoxic drugs. They can upregulate a molecule called BCL2. And what BCL2 is, it also sits on the membrane, but what it does is it absorbs these BH3 proteins. It sequesters them so they no longer can activate these BH3 proteins, and so then you can't poke holes in the membrane and you can't kill the cell. So if BCL2 is highly upregulated, again, that defeats the conventional cytotoxic drugs. So venetoclax, this newer cytotoxic drug, bypasses all this stress signaling and goes directly to the level of BCL2. And what it does is it binds to BCL2 and displaces these BH3 proteins that BCL2 is sequestering, and that frees them up then to just to activate BAX and BAC and get the pore made in the mitochondria, release of these proteins and chewing up of the cell. So unfortunately, it's very easy to see how venetoclax can be overcome, why it can't cure as a single agent. And the reason for that is that BCL2 is one of only a family, only one of a number of proteins that can actually do this, can actually absorb these BH3 proteins and prevent them from activating BAX and BAC. And so there are other proteins like BCLXL, MCL1, and A1, which when upregulated, absorb out these BH3 proteins. And in the microenvironment where the CLL cells grow, and where they receive the signals which tell them to grow, these microenvironmental signals actually upregulate these proteins, and they can take over the function of BCL2, and so then venetoclax can't kill such cells. And so always when you treat with venetoclax, you're left behind with these types of cells that will eventually grow out. Ibrutinib is the first of the kinase inhibitors that became available around 2014, and it has a totally different mechanism of action. How it works is that it blocks the signals which tell the CLL cells to grow. It's not interested in killing the cells, it's just interested in stopping them from growing. And so we've mentioned the importance of signals through the B-cell receptor to stimulate the growth of CLL cells. These signals are sent into the nucleus to tell the cell to divide through a protein called BTK, or Bruton's tyrosine kinase. Ibrutinib blocks Bruton's tyrosine kinase, and so what it does is it just deactivates the CLL cell. And then what the CLL cell does is it just comes out of this microenvironment and eventually gets cleared from mechanisms we don't quite understand. But then it's really easy to see how ibrutinib can't cure as a single agent, because although BTK and B-cell receptor signaling is an important driver of CLL growth, as we tried to talk about in the microenvironment where the CLL cells are nurtured and grow, there's a whole host of other signaling pathways that are still active. Things like the Wnt signaling pathway, the Notch signaling pathway we've talked about, other signaling pathways that are not blocked by BTK inhibitors. And so these types of signals can sustain the CLL cells in the presence of ibrutinib, and again, buy them time to eventually start to progress and grow. Antibodies are sort of a combination of cytotoxic drugs and immune stimulatory drugs. What they are engineered antibodies, even engineered B-cell receptors that are water soluble, that bind to a marker that's only found on B cells called CD20. And so the antibodies only affect B cells. They don't affect any other cells in the body, so they're highly selective, and that's one of their advantages. They don't cause a lot of toxicity to other organs. And how they work is that they work in a number of ways. So by binding to CD20, they can actually kill CLL cells in some cases. More importantly, what they do is they bind to CD20, and then they recruit other immune cells that can kill, so-called killer cells, that can be brought localized to the surface of the CLL cell and then deliver a killing signal. And so Rituxan it was available in 2014. Obinutuzumab is the newer antibody. It's made a little bit differently. It binds a little bit more strongly to CD20, and thus may be able to kill them a little bit better and recruit a little bit more of killer cells a bit better. However, on their own, antibodies as single agents in general are not very effective in CLL. Their use is best combined with other drug classes. So I'll talk about bone marrow transplantation, which still has a role in the treatment of CLL. It's a very toxic procedure, but it can provide long-term disease control and potentially even cure forms of CLL when that is no longer responsive to some of the other drug types, or for which there really are no drugs on the future that can potentially help control CLL. And how a transplant works, very simply, is that bone marrow cells from a donor are injected into the patient. And these bone marrow cells, 50% of them are immune cells called T cells. The job of T cells is also to recognize foreign material and get activated and kill off the foreign material, which is generally infectious agents. T cells in a recipient recognize that they're not in their normal environment, so they basically fire off and reject the entire patient. So there's a systemic rejection of the patient. And what that does then is it causes damage to healthy organs like the liver, spleen, liver, intestine, skin. That's called graft-versus-host disease. But these T cells can't distinguish between healthy cells and leukemia cells, so they also reject the leukemia cells, and that's called the graft-versus-leukemia effect. And that's essentially the curative aspect of the transplant. So the problem is that because the graft-versus-host disease can be so toxic that the sort of a rule of thumb is that 30% of patients who undergo transplant will die of the toxicity. Another 30% will probably have significant complications of graft-versus-host disease, so their quality of life is significantly impaired. And then another 30% may have, if you will, prolonged disease control. But one of the problems with CLL is that it eventually does escape even the graft-versus-leukemia effect and can start to grow again. So to sort of harness the graft-versus-leukemia effect of T cells and avoid the problems of graft-versus-host disease, this therapeutic modality called CAR T cell therapy has been developed over the last 10 years or so. The premise of CAR T cells is that one uses the T cells of the patient himself. If you take them out of the body and then infuse them back into the patient, obviously they can't cause graft-versus-host disease because they are in a normal environment. But they obviously can't cause graft-versus-leukemia, or the patient wouldn't have developed leukemia. So what's done is that those T cells are genetically engineered to express an artificial protein that's made up of two parts. One is a part that's engineered to bind to a structure on the CLL cell, and then on the other part is a signaling molecule. And so when T cells that express this receptor go into the body, they'll bind to CLL cells because they are directed to respond to antigens, to markers on the CLL cell, and they guide the T cell towards the CLL cell. And then once they bind there, the second component delivers a signal into the T cell that gets it activated so that it can clear the CLL cell. So this approach is useful. This is a patient actually from Sunnybrook who was treated with CAR T cells at the National Institute of Health in Washington. And this was the patient's blood before treatment. As you can see, he had a lot of these CLL cells. This is a CAT scan of the patient. This is a cut through his abdomen. They're looking at his kidneys, his spine, but you're seeing this massive white stuff, and that's lymph nodes. That's CLL cells growing and no longer can be treated with the drugs that were being used at the time. And so 13 weeks after treatment, throwing in these T cells, you can see that the T cells in the blood were cleared, and as well there's lots of empty space now on the CAT scan. The lymph node masses were also cleared. So CAR T-cell therapy can work. It's not as non-toxic. It still has a lot of upfront toxicity, but it's true that after a few months, graft versus host disease is not a problem. The problem is that it's not really that effective in CLL. Although really only about 25% of CLL patients who get CAR T-cell therapy get a remission like this, and the remissions are often short-lived. And many patients don't actually respond to the CAR T-cell therapy. It's a little bit different than some of the other lymphomas where the CAR T-cell therapy appears to be more effective. And the reason for that is that we've talked about one of the hallmarks of cancer is that cancer cells are immunosuppressive. They acquire the ability to shut off T cells. For CLL cells are probably the most immunosuppressive cancer cells known. And they're highly immunosuppressive. They make factors like something called IL-10, which shuts down T cell activity. And so it's sort of no surprise then that if you put in allogeneic T cells that can also cause graft versus host disease, or you put in CAR T cells, then the CLL, these T cells can home into the region of the CLL cell, but the CLL cell will just shut it off, and so the efficacy is lost. So research is ongoing to try and develop ways to make CLL cells more immunogenic, if you will, better able to be recognized by T cells and be killed by them, but that's ongoing research. So I've described the types of drugs we use to treat CLL. And we use them we have treatment algorithms that we use to treat CLL. These algorithms are actually undergoing active revision with time, but this is what I've described here is what we do now. If you're a CLL patient and you've had your diagnosis, you've had your watch and wait period, you've developed symptoms that require treatment, and so this is how we make our treatment decisions. So if the IGVH status is mutated and you're reasonably healthy, and that usually means that you don't have a lot of other organ damage, other sicknesses. That usually means being less than about 70 years old and not having a lot of comorbidities like heart disease or kidney disease. And we use a regimen called FCR, which can be toxic, but it's very effective for this group of patients. So effective, in fact, that it's thought that maybe about 5 to 10% of patients who fall into this category can actually be cured with FCR. So I've emphasized the incurability of CLL, but there are a few cases now where this treatment can cure. But you have to have a very specialized form of CLL to be able to experience that. On the other hand, if the IGVH status is unmutated, what we've learned is then FCR can't cure, can give good remissions, but for various reasons, we don't think it's worth giving FCR to patients where you're not have a chance of cure or at least prolonged disease-free survival. And so then those patients are given ibrutinib as first-line treatment. If you have the IGVH mutated status, but you're a little bit too frail to get FCR treat to be able to tolerate FCR, then we use an old-fashioned cytotoxic drug called chlorambucil with the newer antibody called obinutuzumab. Don't generally use ibrutinib first line for such patients. And if the CLL cells have what's called, what we've talked about, deletion 17p or the loss of p53, we don't give cytotoxic drugs because intrinsically they can't, these CLL cells that have lost p53 can't be killed by cytotoxic drugs. So for such patients, we use ibrutinib first line. Talk a little bit about these regimens. FCR is a combination of fludarabine, cyclophosphamide, and Rituxan. It's given for 6 cycles every 28 days. Each cycle consists of 3 days of treatment, with Rituxan given on the first day and FC given for all 3 days. As mentioned, it's potentially curative therapy for otherwise healthy patients with the IGVH mutated status, but really nobody else. It can be quite toxic. It can be quite immunosuppressive on its own, can cause a lot of infections, may impair the bone marrow sufficiently that transfusions are needed. It can cause a lot of stomach upset. And there's also a dark side, I think, to FCR that we recognize, which is that because it acts by causing a lot of genetic damage to the CLL cells, it also can cause genetic damage to other cells. And there's not really much selectivity for where the drugs act. And so over time, there's a risk of, again, if you've got genetically damaged cells in other organs, then they'll go through the process of initiation. They become initiated by FC, and then they go through the process of progression and develop into a cancer in that organ that can be even more worse than the CLL itself. Chlorambucil and obinutuzumab is, chlorambucil is given twice a month for 6 months. Obinutuzumab is given 4 times over the first month of treatment and then once a month after that. It's an effective and relatively non-toxic treatment, especially for IGVH mutated patients who are expected to have too many side effects from FCR. And it's very effective. It can give 4 to 5 years of disease control before relapse occurs. Ibrutinib is this pill we've had since 2014. It's first-line treatment for patients with unmutated IGVH status or the deletion of 17p, loss of p53. It can give 5 to 7 years of excellent disease control. However, there's actually a number of cons associated with ibrutinib. It has to be taken daily until disease progression. There's 3 pills a day, every day. And there's many side effects, especially even in older patients. These side effects include risks of bleeding. Many patients develop joint pains. Nail and skin changes can be bothersome. Many patients just don't feel well on ibrutinib. And it can cause high blood pressure and also can cause an irregular heartbeat, which will require then visits to cardiologists and the accumulation of additional medication. So it's a great drug, but it's got its issues. What's our algorithm for first-line treatment? The algorithm for second-line and later treatment is evolving. At the current time, if you relapse after chemotherapy, so after FCR or chlorambucil or obinutuzumab, we generally try to use ibrutinib. If you're on ibrutinib and then relapse, that's when we use venetoclax. Now, the problem with using venetoclax is very effective and can probably give you another 4 or 5 years of disease control, but we don't really have anything after that. So when the disease recurs on venetoclax and it's progressed on ibrutinib, you're in this situation where don't have a lot of other modalities to use. So it's at this point in time when you start venetoclax as second-line treatment that one would talk about undergoing an allogeneic bone marrow transplant as part of the treatment algorithm. Again, if you're really judged that you can't tolerate the side effects of allogeneic bone marrow transplant, or you don't want to do it, then the idea would be just to continue venetoclax, knowing it'll relapse and trying to get involved in clinical trials to try and deepen responses to venetoclax. So just a word about venetoclax itself, how it's being used. It's a pill. It's generally very well tolerated. They sometimes make the white count go a little bit low. There may be some diarrhea associated with it. An advantage is that although it has to be taken daily for a reasonably long period of time, there's actually a stopping point. So currently, we stop it after around 2 years. It can actually be probably stopped even earlier. Studies are ongoing to assess that. But that's an advantage. It's compared to ibrutinib. Ibrutinib you have to take forever. Venetoclax you can take for a finite period of time. And it's very effective. There's likely more than 3 to 4 years before a next treatment is needed. And in second-line treatment for CLL after a chemotherapy relapse, that's excellent. One unusual aspect of using venetoclax that's different than some of the other drugs is that if you have a lot of CLL cells around at the time you start venetoclax, as we showed, venetoclax is really downstream of the cell death signaling pathway. So you can kill a lot of CLL cells at once, and if you kill too many CLL cells at once, they release their intracellular contents into the peripheral blood, and that can then plug up kidneys, that can cause gout. And so to overcome that, what's done is that when you institute venetoclax, you start with a very low dose and have to come in weekly to up the dose, which can be a little bit tedious. But once you're on about the 400 milligrams, the recommended daily dose, it's generally very well tolerated without some of the chronic issues that are associated with chronic ibrutinib usage. Importantly, we think that because venetoclax acts downstream in the cell death pathway and is not supposed to cause much genetic damage, then it may not select as much for more aggressive leukemia cells when they relapse. So the idea is that not as many genetic mutations have occurred in these cells. They may not be as aggressive when they relapse, and so you may be able to use venetoclax as effectively the next time you relapse, which would add another sort of line of treatment onto the treatment course of the patient. However, that's more theoretical at the moment. We don't have long-term data on venetoclax, only really about 4 or 5 years at the moment now. So it's probably going to take another 5 years before we'll be able to really make that statement with accuracy. So I may have been a bit pessimistic. I don't want to, but the glass is half empty, the glass is half empty when I'm talking about these newer agents, but make no mistake, the life expectancy for patients with CLL has been significantly altered and improved with these newer drugs. So what I've tried to highlight here is this was the typical clinical course of a CLL patient before 2014, basically from the time of treatment, because through a number of relapses, you would run out of things that one could be done probably within about 10 years. So I've put in a sort of an average lifespan of 14 years. Before 2014. And of course, the reason is because of the acquisition of additional mutations, acquisition of genetic mutations with ineffective therapy. Now, we have the ability to use our treatments in a selected manner. We have a completely new arm of treatment, the kinase inhibitors. And so the life cycle of a CLL patient, you'll still go through these periods of watch and wait and first-line treatment and relapse and second-line treatment and relapse. But the idea is that, again, potentially with cholesterol lowering, you can extend the watch and wait period by a few years. With the first-line treatment, you can extend disease-free survival by a few years. Same goes for third-line treatment, which one didn't really have in 2014. Maybe CAR T-cell therapy might be another arm. You can see that the time frame is the same, but now you can add up potentially an additional 10 years onto the expected course of a CLL patient. And if the diagnosis is CLL is usually diagnosed when a patient's in his 60s, if you can get 25 years out of that, you're in your mid-80s, and the truth is you can't ask for much more than that. So I've given sort of the algorithms we're using right now. What do I see in the future in the next couple of years? I think probably venetoclax will probably be first-line treatment, probably with obinutuzumab, really for everyone. Because it's effective, it should be expected to be able to still preserve the curative aspect of FCR without sort of the genotoxic damage. So that group of patients that would get FCR would still be cured. And then the idea is that the remissions with venetoclax in first line might well be 5-7 years, possibly with less genetic damage. And so you may be able to retreat with venetoclax, unlike trying to retreat with other cytotoxic drugs like fludarabine or chlorambucil. Again, the caveat is this may not be true. I also think acalabrutinib may well replace ibrutinib. So ibrutinib is very effective but has a lot of chronic issues. Acalabrutinib is supposed to be a more selective BTK inhibitor. In that case, it's supposed to have less side effects, and so might be better tolerated. Again, we're doing a trial at Sunnybrook using this drug. My first experience with it was this year, but the literature was this month. But the literature elsewhere, the teaching is it's supposed to be a better tolerated drug. In which case, then, we would probably want to use it first because of its less side effects. But in this case, then, because ibrutinib then is less specific for BTK and some of the toxicities are because it inhibits other enzymes, then the idea is because it's more toxic, paradoxically, it might also still be effective when acalabrutinib loses its effectiveness. So it might actually then be an additional arm of treatment that can buy you another few years before you have to move on to venetoclax or to additional therapies. So I just want to close by saying that ibrutinib and venetoclax are sort of becoming mainstays of how we manage CLL, but obviously they need to be improved, and clinical trials are needed to do that. So at Sunnybrook, we have a phase 2 trial going on right now where we're adding an additional kinase inhibitor and a cytotoxic drug called dexamethasone to patients who are being treated with ibrutinib. And the rationale for that study is that, and this is sort of a caricature of the microenvironment, the lymph node or the bone marrow, and a picture of what's going on when a patient takes ibrutinib. The signals from the B-cell receptor are blocked nicely by ibrutinib, but the other signals in the microenvironment are not and can sustain the CLL and allow it time to acquire additional mutations and to progress. So some of these additional signals can be blocked by a drug called a kinase inhibitor called ruxolitinib. And so we're adding ruxolitinib to try and get rid of these additional signals. And then we mentioned we don't see ibrutinib doesn't really kill CLL cells directly. It just inactivates them, but it would make them more sensitive to some killing agents. And that's why we're adding in a classical glucocorticoid to try and kill CLL cells that where their kinase inhibitors, where their additional signaling pathways are blocked, and keeping ibrutinib. And so we've shown that ibrutinib and ruxolitinib, very safe approach, and now we're adding glucocorticoids to the regimen. So that trial is ongoing, and I'll just take this opportunity to advertise that. Anyone currently on ibrutinib or about to start ibrutinib in Ontario is actually eligible for this trial, and there are other trials around the world designed to try and deepen responses to these inhibitors. So I'll close there, and I've droned on, I guess, for quite a while, but there's still, I think, a lot of time for questions, so I'm happy to take some. Sure. Yeah. Well, it does that. So some of the side effects from ibrutinib are because although it blocks, so there's 400 different kinases in the body, and they all have sort of similar structures. A kinase means that it takes a phosphate group and puts it on a substrate, a protein. So all of them have some, their variations on that philosophy. So if you're blocking the kinase aspect of Bruton's tyrosine kinase, you can't get it quite exactly. So that it blocks BTK, but it also blocks other proteins in other cells. So for example, with bleeding with, bleeding with ibrutinib, it's probably not because ibrutinib is blocking BTK in those cells. It's because it's blocking some other kinase inhibitor that's involved in the function of platelets. So you're getting that block of platelets. That's why you get bleeding. Acalabrutinib is a different molecule. It blocks BTK, but it doesn't necessarily block those other signals, those other kinases. And so, for example, you're not supposed to get the bleeding that you get with ibrutinib. You're not supposed to get the atrial fibrillation that you get with ibrutinib, which is presumably ibrutinib blocking some kinase in the heart muscle or that impairs it. So that's why it's just the acalabrutinib and ibrutinib are equally able to block BTK, but ibrutinib can also block other kinases, and that's why it's toxic. Now, again, you're on a clinical trial because it's not clear that that's totally advantageous, because it may be that one of the reasons that ibrutinib is so effective is that it is blocking these other signals in the microenvironment that are helping the CLL grow. So that's why you're on the clinical trial, to see is that the best, is that a better drug? You can anticipate it might not be, but again, that's why you're on a trial. We don't know. We have to see in the next few years. Okay, sure. Well, I don't know that you can do that. So what you're asking is, how do you pick up those initiating mutations? And presumably, it's during the course of normal B cell function. So B cells, as I mentioned, throughout your body, their job is to proliferate in inflamed areas where infections occur, and that's a toxic environment. It's part of living. And so in the process of that, years before the diagnosis of CLL is made, that's where the initiating event occurs. So the only way to do that is just live in a bubble for your whole life and not be a human being. And even then, your natural processes of human biology will generate some oxygen-free radicals that can cause some genetic damage. So I don't think it's that important to try and think about the initiating events. We don't think that there's anything in the environment that actually can cause this genetic damage. Clearly, if there was, you'd remove it from the environment, and that would be a way to stop CLL. But I think it's an outgrowth. Again, if you take mice and you just put them in a cage, mice live about 2 years, and you have them in a completely non-stressful environment where you give them the best food possible, no infections or anything, 30% of them will get CLL just from the natural aging processes. So I don't think stopping the initiating event is important, but I do think what's important is trying to reduce the factors that tell the CLL cell to grow, of which cholesterol is one that you can deal with. There are other factors in the blood that can also called inflammatory factors that can actually stimulate CLL cells to grow. And so actually at Sunnybrook, we're developing a trial where we're using a molecule called anakinra, which is an antibody, which is an antagonist of a protein called IL-1, interleukin-1, which stimulates, which is sort of causes a lot of inflammation. And what we found is that if we block IL-1, then the CLL cells can be more easily treated. So we're quite excited about doing that in first line, in the watch and wait period. We would, when patients are diagnosed and we can see that they're progressing towards treatment, could we intervene with this anti-inflammatory strategy and actually, again, I don't expect to cure anybody, but to delay progression by another few years and put that 25-year expected life expectancy to 30 or 35 years. Sure. Tell your doctor to refer you. It's also on. There's an NIH. All clinical trials in North America have to be registered with something called the NCT clinical trials, and this trial is registered there. Yes? Well, again, it's to try and reduce the factors that stimulate B cells to grow, and a lot of these are the cholesterol seems to be an amplifying factor, but there are some other inflammatory factors. I mentioned IL-1 upstream, right? Blocking that seems to be useful. The best anti-inflammatory is exercise. So 45 minutes of cardiovascular disease, 5 to 6 days a week, with increasing intensity because you get used to the level of exercise you have, so you have to increase the intensity. And and calorie restriction, keeping your calorie count below 2,000 calories a day, counting what you're putting in your mouth, and trying to get rid of your abdominal fat pad. Abdominal fat is basically a store of fat that every night the fat stored there gets released into your bloodstream, and basically packaged as lipoproteins and can be used by transformed cells, not just CLL cells, but early breast cancer cells, early prostate cancer, early colon cancer. These are the things that you can do. At some point, it's out of your control, though, because if the genetic mutations are such that the CLL has progressed to the point that it's now independent of these external controls, you can't do anything about that, but that's when you come to the doctor and he'll give you some treatment. Sorry. It's hard to do a presentation like this, I have to tell you. Yeah. No, that's based on with ibrutinib as a single agent. So as a single agent, it can only control the disease. It can't cure. That's clear. So what's being done, for example, is again a variant of the trial that our variant. So in the U.S., for example, patients are trying to use venetoclax with ibrutinib. So combining venetoclax and ibrutinib. The idea there is that your ibrutinib deactivates CLL cells, but it doesn't. It's not clear how they can even kill those cells. So then you give venetoclax, and it should be more effective because ibrutinib's dropping some of those survival signals that are upregulating the non-BCL2 family members that can cause venetoclax resistance. So you can expect, hopefully, to get a more effective use of venetoclax and then ibrutinib as well. If you could actually get rid of every last CLL cell, then potentially you could stop ibrutinib and wait for the relapse to occur. So these are things that are trialed. It's not clear that ibrutinib is actually, again, because there's additional survival signals, it's not clear that venetoclax and ibrutinib is the best combination, but research is needed to develop better combinations. And in fact, again, ibrutinib, all of these things now we can start to rationally mix and match. So one of the things that ibrutinib does it seems to actually block some of the production of immunosuppressive factors by CLL cells. So using ibrutinib with bone marrow transplantation or using ibrutinib with CAR T cell therapy may incrementally make those modalities better. And then again, you can stop the ibrutinib after a finite period of time. Well, what's your definition of hope? Father Time is undefeated. Well, if there's only 40 mutations, then basically around the world, there will be some patients who have similar forms of CLL. So the patterns of behavior are similar. But in general, each patient, yes, is a little bit specific, but the overall patterns may not be that different. Some have aggressive disease, some have less aggressive disease. Unfortunately, the mutations, you would think, okay, identify the mutations, develop a drug, target that mutation. That's ongoing research, but that's many, many years away. But remember, there's only certain patterns. They're only relevant if they affect about 13 or 14 different signaling pathways that are required to control the cell. So they'll all segregate into those pathways. So the overall patterns of that's why all cancers have these certain hallmarks, because the genetic mutations get selected for those which can cause more aggressive disease. And there are finite numbers of signaling pathways that can be mutated that will cause cancer. Exactly, and then without causing toxicity, because the more drugs you put in cause toxicity. But I think then the idea would be to basically, again, control disease until the natural lifespan of the patient. You're not going to live longer than your parents did, to be honest. You know, that's the ultimate genetic program. Do you know what I'm trying to say? I'm just trying to say the treatment of CLL is in a non-toxic manner to allow the patient to live to their natural lifespan. Yes? Yeah, so the 3-pill-a-day regimen, the reason you take that is it's 420 milligrams, it's absorbed into your bloodstream and gives a concentration of ibrutinib in your bloodstream of about 400 or 500 nanomolar. And then that amount of concentration of ibrutinib is able to block all of the BTK in your bind to BTK in your CLL cells and block them. 2 tablets a day is just a little bit further down on that curve, so you can block most of the BTK and possibly get a similar effect. There's studies around to try and lower the dose of ibrutinib, and sometimes you're forced to do it because of symptoms. But in general, what it does mean is that there are fewer, some CLL cells are around that are not necessarily having BTK blocked, and those might well be selected over 5 or 6 years. So in general, it's probably, it's good to again, look up on this national NCT site or even to ask the Leukemia and Lymphoma Society for any clinical trials designed to deepen responses to ibrutinib so you can potentially get off it at some point. I think the way it might work is for symptoms. So already right now, if you're too symptomatic on ibrutinib, you can go to a drug called adalasib, which I didn't talk about, but which is generally a well-tolerated kinase inhibitor. Again, I don't know enough about acalabrutinib. I've just heard that it's touted as being, touted as being less toxic. There's been a few early trials out, and I was a little bit, I thought it looked like there was still a significant risk of bleeding. So it may be that there's some sales hype there from the drug companies that it's less toxic, because clearly that's what you would want. So it's possible that when it gets licensed, it may well be licensed as an alternative for ibrutinib. So if you're intolerant to ibrutinib, you can use acalabrutinib. But I would argue that if you're coming off ibrutinib because your CLL is progressing on ibrutinib, it doesn't make any sense that using acalabrutinib will be useful, because you're presumably resistant to BTK inhibition. Yes, sorry. Don't look at it. No, in terms of first-line therapy, avoid first-line therapy as long as possible. Again, for a number of reasons, I do think if you can avoid first-line therapy for a couple of years, I think venetoclax will be your first-line treatment. And then by the time you would need ibrutinib, as I said, acalabrutinib might not cause the easy bruising. But if your only choice, if you're an Ontario resident right now, you've got the unmutated form, or you've got a 17p deletion, then ibrutinib is your drug of choice. It's a great drug. I mean, it's revolutionized the treatment of CLL. The type of bleeding you get with ibrutinib is more unsightly. It's kind of like the bleeding you get when you take a baby aspirin. So I would just say if you're vain about bleeding, just wear long sleeve shirt. I know that sounds very sort of cruel or facetious, but it's a risk benefit thing. I don't think there's anything you can do about it. And don't take any other anticoagulants. So don't take aspirin with it, and try and avoid, if you've got heart problems and atrial fibrillation. Even then, we can still add additional anticoagulants on, and bleeding is not really a significant issue. It's not life-threatening bleeding that you normally get. It's more of the cosmetic type of bleeding. Yes. Definitely. Again, the allotransplant really is not given to anyone over 70 years old, and that's the reason for that is, and if you've got any comorbidities like liver damage, kidney failure, or even chronic renal failure, even some chronic heart issues, previous heart attacks, probably the transplant unit won't offer you the transplant, because your chances of making it through the transplant mortality becomes much higher. For CAR T-cell therapy, again, this is mainly in the United States. I have experience with CAR T-cell in the context of this clinical trial at the NIH, which we sent about 10 patients down for that. They had a criteria of I think about 65, and the reason for that was that the toxicity is quite high up front. You put these T cells in, they're firing against the leukemic cells, they're releasing all sorts of inflammatory factors, and you can get really sick from that inflammation. Your heart has to be able to tolerate it. You can get even with some encephalitis, some brain impairment because of this toxicity. That's being worked out. In Canada, the only way to get CAR T-cell therapy now, I think, is to go to any of the centers, mainly in the US or Europe, that'll sell you anything. And so if you pay close to $1 million, they'll do it for you. I think we're a little bit more responsible here. I think the goal is to try and either wait for that to be significantly improved, or try and rationally use what we have. And again, I don't know. Again, probably commercially, if you go and go to the States and buy the CAR T-cell therapy, they probably have similar sort of age requirements as bone marrow transplant. They may be a bit more liberal, so maybe in your mid-70s, as long as your other organs are in good shape. Again, rules of thumb would be avoid first-line treatment, again, basically calorie restrict, exercise. But again, if treatment comes, follow the treatment algorithms. And to be honest, so there are what's on the horizon. I mean, there are other drugs on the horizon. So we've talked about venetoclax being easily outwitted by the upregulation of these BCL-XL and MCL1, and so inhibitors of those drugs are being developed, of those proteins are being developed, and should potentially provide another arm of therapy. I think the CAR T-cell therapy will probably be optimized, and in the next 5 to 10 years, and to the point that it could easily be curative. There are things called chimeric antibodies, which glue T cells to CLL cells. So these are molecules that can just get injected and will attract your T cells to the CLL cells, and so that provides potentially a much safer form of CAR T cell therapy and allogeneic T cell therapy that may potentially have some curative intent. There's an antibody called daratumumab, which is used in myeloma. that's probably going to be active in CLL and may again add another arm. I think I just follow the algorithms that we have right now, and I think something will turn. Well, there's certainly progress. What I've tried to do here is just impart what you can expect in the next few years. Those drugs are all being actively investigated, but I think they're years away, 5 to 10 years away from entering clinical practice. Yes. I mean, so there was a study from the Mayo Clinic that Tate Shanafelt did it 15 years ago, showing that vitamin D deficiencies were common in CLL, but they're not that common, and so vitamin D supplements are useful. You know, it makes sense they should be useful, especially for patients like, you know, people who live in Ontario, to especially supplement over the winter months and use doses of around 2,000 units a day in the winter months. In the summer months, try and get at least 20 minutes of sun exposure to get your vitamin D complement up. The problem is I just read in the New England Journal about 4 weeks ago that there were randomized studies of vitamin D that didn't show any effect. Again, that's the population of studies. We recommend vitamin D to most of our patients. Dr. Shanafelt did a study of green tea extract, which in early stage patients that seemed to be positive. Again, green tea extract works as I think as an anti-inflammatory, and you can probably achieve the same effect with increased exercise and calorie restriction, and probably more physiological than buying a lot of supplements. Fish oil, again, is a great anti-inflammatory, and again, inflammation is what you're trying to deal with to try and stop the proliferation of CLL cells. Again, the best anti-inflammatory is exercise and calorie restriction. So vitamin D we generally recommend. That's about it. I don't really recommend fish oil as much. Again, in the New England Journal, despite like 50 years of using fish oil as an anti-inflammatory, again, just a few weeks ago there was a negative study. So it's been going on for like 30 years. Some studies are positive, some negative. Okay? Okay, thank you.